everyone. Welcome to Conversations. I think we'll still have some people trickling in, but thanks for coming. We're so excited to have you here. Thanks for coming early, just in case you're watching the Super Bowl later. I just want to do a little housekeeping, and then I'm going to turn it over to Olivia and Lexi. Welcome to Conversations. If you haven't been here before, welcome. If you're usually here, awesome. I'm Sydney. I'm in the 2019 cohort. And what we usually like to do is just have kind of like a short discussion for 30 minutes. And that first 30 minutes is recorded. And then after 30 minutes, you're welcome to leave if you have to. It's not rude or anything. Feel free to jump off. And if you want to stay on, that's cool too. Can continue asking questions. Lexi and Olivia will be here for the whole hour. And yeah, you're welcome to turn your camera off too. If you're doing something, like, feel free, no, you don't need to have your camera on. And yeah, last thing I'll just plug, we're doing an impromptu conversations this week on Tuesday night about Myanmar. And I'm not sure if it's Mimi or Mei, but she will be speaking with Sarah Baran about what's going on in Myanmar. So that will be at 7 o'clock on Tuesday night. And it'll be recorded too, if you can't make it. Awesome. I'm going to turn it over to Olivia.
Sounds great. Thank you, Sydney. Hi, everyone. Lexi and I are super excited to be doing this. Also, major props to Lexi for being the driving force behind this in a lot of ways. So really appreciate that. We are both super passionate about this topic. I'll let Lexi give her intro, but I guess just for me, why this issue is important to me. So I studied the history of women's health a lot in undergrad. And after college, I worked at a women's health telemedicine company, and then with a doctor in Amsterdam named Rebecca Gomper, has an organization called Women on Web, which she basically relies on legal loopholes through which to provide women abortion pills around the globe. And feel very lucky to have met Lexi early on through this community. So I'll maybe let Lexi intro herself, and then we can go to our slide portion of this conversation.
Thanks, Olivia. I couldn't feel more similarly. I feel so lucky to have met you through this program, and so grateful for our conversations, because like many conversations on this issue, your views get more nuanced and informed the more people you talk to. And background on me and why I care about this so much. I am trained to become a doctor and have a very strong passion around women's health. I don't know what specialty I'll go into, but I know that advocating for women's health will always be a part of my career. And I've gotten the opportunity to work for various programs, like most recently in Mississippi at the Department of Health there, trying to address maternal mortality there and racial disparities in healthcare there. And I also, when I was an undergrad, I was at the University of Notre Dame and was exposed to how tense conversations around this particular pillar of women's health, being abortion, can be. And after getting to form very close relationships with people at Notre Dame that think very differently than I do about this topic, it made me sad that our conversations are the way they are about abortion today. Because they have the potential to be a lot more fruitful, I think, and do better by the women and patients that abortion affects. And also hopeful that there is space for us to have conversations about this that do just that. So that's when I became really passionate about having conversations of care and concern, specifically about abortion. Because for reasons we'll go into, they sometimes do not come easily, and they can be very tense. And so that's why Olivia and I chose to talk about this particular topic at this particular time. And so without further ado, I'll share the slides and Olivia can get started.
Awesome, thank you. And I guess a few kind of disclaimers while Lexi's getting the slides up. One is that we're very aware we are telling a US-centric story here, which mainly is based on our backgrounds and what we've studied and learned about. So wanted to flag that from the beginning. And we also wanted to flag from the beginning that this is obviously a sensitive subject, and there are even for additional sensitive subjects that come up when we talk about abortion, like rape, like abusive relationships. So a trigger warning there that those do come up. We wanted to say, feel free to interrupt us whenever or chat questions in the chat, whatever you feel comfortable with. And I think, as Lexi said, our real goal here is that we know conversations about this can often either erupt into emotional screaming fits, or it becomes really clear that you feel like you just can't talk to someone about it because their opinions seem so firm and inflexible. And we both really think that's very toxic. And it's important to be able to speak intelligently about abortion. And to have kind of some grounding through which to have those conversations. So we hope this brief conversation allows a little bit of that. So I guess we can start the slides. And thank you, Lexi. And we wanted to, part one, just show you what often a conversation about abortion erupts into, just with some brief images, and to show you kind of, this is what it can look like, and this is not what we hope today, and your conversations about this with friends and people in your lives moving forward look like. It becomes really political really quickly. And as I'm sure we all are aware, conversations about abortion can become co-opted by political views, other issues really quickly. This is one particularly egregious example, which I'm sure some of you have seen, the Todd Aitken's quote on rape and abortion. And you can actually go to the next slide as well, Lexi. Thank you. Yeah, I think these are just additional examples of what this can look like. And I think an interesting thing in all of these posters is that the woman who gets the abortion is never centered in any of these conversations, which is really dangerous. And we hope that our conversation today will provide you with some tools and ways of thinking about why that is, and why having conversations grounded in these types of either fear tactics or emotionally manipulative tactics can be really, really dangerous and can make it feel like you can't talk, which is, again, our hope of this conversation is that you'll go and chat with everyone you know. So hopefully that happens. And yeah, here we have Ted Cruz, but pregnancy is, not a life-threatening illness. But again, and here we see it also being used with the First Amendment, which is a new one. If babies had guns, they wouldn't be aborted. This is all, again, just an overview of what the conversation can look like now.
I see Courtney raised her hand, so feel free to unmute and say something or ask your question, Courtney.
Sorry, I'll wait till the end. I didn't actually mean to raise that yet. I'm on my phone. I was just looking for where it was.
That's great.
Okay, but feel free, anyone else, to interject, raise your hand. We really want this to be conversational. Okay, so this is a graph I made because before we get started, I just wanted to kind of acknowledge this dynamic that I'm sure this graph I'll revise over the years, but in my own head, I've kind of realized that sometimes the questions that have the clearest answers, like the ones we can get to and demonstrate with facts or scientific experiments, are the ones where it's easy to have curious and open-minded conversation. But then the questions that will never have clear answers, such as when does life begin, are the ones that are very emotional and intractable, and sometimes become, instead of a curious and open-minded conversation, more of a statement of tightly held opinion that unfortunately misses the opportunity to hear any other sides of the issue, which of course is a great paradox, because a question like when does life begin is one that people have been wondering about for thousands of years. So to treat that question as something that you as one human being have the answer to kind of, I think, misses the gravity of the question in the first place. And so I just wanted to kind of share this graph at the beginning because a lot of times, and I'm sure all of you have either been a part of a conversation like this or seen a conversation like this happen on the news or with your families or loved ones, the conversation about abortion can boil down to, well, is it murder or not? And unfortunately, it's Olivia and I, it's our belief that that's just, it doesn't do justice to how important it is to talk about this issue with care and concern, instead of with blinders on to the reality of women's lives as lived. So yeah, just gonna start with that, and please feel free to ask questions about this as we go on, but just to acknowledge that kind of elephant in the room of what the conversation can be reduced to, and state that we're trying to move away from this question that will never really have an answer that we can all agree upon into an intelligent conversation where we're grounding ourselves in lived realities and with a mindset of, okay, given that we won't agree on this question, let's have a conversation about how we can do the best by our fellow human beings and their well-being. Okay, so those images that Olivia showed you at the beginning kind of have an effect on our laws, and she's going to now talk through some of that.
Thank you, Lexi, and thank you for your graph, which I love, and it seems like people in the chat love as well. Yeah, so we wanted to give a brief overview of our laws, which sort of reflect some of those sentiments and conversations we showed earlier. So the first, and again, many of you may know this, many of you may not. We wanted to have everyone to have a sort of basic understanding and common dictionary here. So the first are TRAP laws, which are targeted restrictions on abortion providers, basically making abortions really hard to get in certain states. And oftentimes TRAP laws basically use a state's rules for ambulatory surgical centers and apply them for abortion clinics, even though abortion clinics have been proven to not have the same level of risk and not use sedation and lots of things that make applying regulations for one group on the other a bit confusing. And TRAP laws have also recently been in the news because a lot of recent Supreme Court cases have been around them. So Whole Women's Health was a 2016 Supreme Court case, which basically struck down Texas's TRAP laws, which had required hospital admitting privileges of doctors who provide abortions, and it also made it so those abortion providers had to satisfy various other criteria that are applied usually to surgical centers. That was struck down by the court, and it developed a balancing test of burdens and benefits. And in that case there with Texas, they said there would be no benefits for having those restrictions. And so an undue burden with no benefits means those TRAP laws shouldn't be constitutional. In 2020, so more recently, we saw an almost identical case with June Medical, which was around a similar TRAP law, but in Louisiana. And the court struck this down as well, but I think it's worth pointing out that as the composition of the court changes, those laws become a little bit less tenuous. So in 2020 with June Medical, you had the 4 liberals and Roberts say that this is unconstitutional, but interestingly, Chief Justice Roberts agreed to the decision because of the precedent of the case 4 years earlier, but it was clear it didn't really agree with the reasoning there. So this is all to say things are tenuous and it's hard to predict where things are going. Some of the other laws we wanted to point out are, so physician and hospital requirements, I kind of touched on with the TRAP laws, but counseling. So 8 states at this point mandate that women be given counseling before an abortion. That includes misinformation at this point. So many more states beyond the 8 require counseling of some sort. These 8 require counseling that either talk about the link between abortion and breast cancer, which is factually inaccurate in 5 states, the ability of the fetus to feel pain in 13 states, and the long-term mental health consequences for women in 8 states. And we will later talk about the Turnaway study, which proves why some of these have factually been proven to be inaccurate. And then I wanted to also quickly touch on the abortion pill. So that has been in the news somewhat recently because the Supreme Court recently reinstated a federal requirement, making it so women had to pick up the abortion pills in person from hospitals or medical offices, even during the pandemic, as opposed to being prescribed them and having them sent to their home. And I just wanted to flag around the abortion pill, which we'll talk about a little bit later as well, but oftentimes, there are narratives that try to make it seem as though this is a pill that very little scientific research has been done on, which really isn't the case. There have now been many articles in medical journals with experiments with thousands of women that have proven, particularly there was an experiment recently done, over 1,000 women in Northern Ireland who secured abortions through the abortion pill, I think in 2010 to 2013, which proved it was safe and effective, proved that it had similar sort of levels of safety and efficacy of those who either took an abortion pill under the supervision of a doctor or who got a surgical abortion. So we wanted to sort of give you guys the groundwork of the current laws here. And I think the next slide just kind of provides the visual of some of those things I touched upon with counseling. So we'll hopefully provide you all with a slide. This is kind of interesting just to see which states require what in terms of counseling information.
Okay, thank you, Olivia. I think she said that she was a law student, but if she didn't, she's a law student. And so it's very helpful to hear her opinions with respect to the legal aspects of this. But so part 2, we're going to move into a little fun section that we have mainly because one of my best friends is a scholar of early modern English literature. And whenever I talk his ear off about issues of reproductive justice, he reminds me that we've been talking about women's bodies for some time and that it is important to start with recognizing for how long there have been conversations about not only women's bodies, but also contraception and abortion. So we thought it would be fun to just share some of that with you. So for example, we can see here Aristotle writing that about how when a baby becomes female instead of male, it's not necessarily a good thing. It's a necessity. And he talks about the monstrosity, though not necessary in regard of a final cause and an end, yet is necessary accidentally. And he talks about various things that happen in the forming of an embryo, saying that if this movement prevail, it will make the embryo male and not female, like the father and not the mother. If it prevail not, the embryo is deficient in that faculty in which it has not prevailed. And so I find this really interesting as someone who spends all their time reading things that were written in the last 20 years to recognize that this conversation about women's bodies and about the ways that they are different or defective or abnormal than that of a man's body is really, it's one that's been happening for thousands of years. And so we hope that you keep this in mind when you are engaging in conversations that touch on issues of sexism or issues that mainly affect women, like abortion. We can also see here, specifically in writings about medical issues that women face, things like they're said to be monstrous and terrible to behold. We can acknowledge that there has been kind of a fascination at best around women's bodies and at worst kind of a painting of their bodily processes in an unnatural light, which if we had more time, we could go into maybe why, and my friend Paki, who's the early modern English literature scholar, could tell you much better than I could about how maybe those narratives also contribute to the reason why women's bodies need be controlled or coerced, given their aberrance from the male norm. And then also, interestingly, people a really long time ago, like Pliny the Elder, were also talking about contraception and abortion, which when I started researching these topics as an undergrad, I was so surprised to learn that contraception and abortion are not inventions of modern medicine. Since the dawn of time, people have been talking about ways to modulate fertility out of necessity. So that is also really important, I think, to consider, and is something that's often lost in this conversation that's very grounded in the now and our current political realities and how contentious this issue can be and how wrapped up in so many other narratives it is. But we've been talking about modulating fertility for thousands of years. And you can see even other writers were also talking about it thousands of years ago. This is really interesting because one of the methods that Soranus wrote about was pomegranate peel, which was also written about in ancient Indian literature as well. And today we now have the scientific research to confirm that pomegranate peel is actually effective as a contraceptive. So they did studies on rats basically, and they saw that 28% of the female rats had decreased fertility. So it's interesting that people actually figured out ways to modulate fertility so long ago. And they also talked about abortion. And as you can see from this quote, abortion was a much less humane endeavor, talking about, bleeding out women in order to have an abortion, but they were talking about it a really long time ago. So yeah, we just wanted to include that to kind of mention that this is not a new conversation. Okay, so that brings us to part 3 of our conversation, which we are perhaps most excited about because as it says on the slide, our conversations have to be better to do better than what we saw at the beginning of this presentation. And our goal is to talk about abortion care intelligently, which means we're going to talk about it with a real concern for people's lived experiences and their realities. And so to start that conversation, it's really important to understand that while abortion is often talked about in the media, in political dialogue as a single issue, it's talked about it that way because talking about it as a single issue is very politically expedient, because it's something that you can polarize people on. It's something that you can create in a black and white way. Whereas if we step back and ask ourselves, like, what part of medical care is abortion care a part of, we see that it's a part of a huge range of different medical services, which include the ones listed on the slide, like attending to maternal health and morbidity and mortality, and infant health, and prenatal care, and contraception, and treatment for sexually transmitted infections, and treatment for infertility if people are trying to get pregnant and can't do that, and sex education, getting clear and consistent education about our bodies when we are young and when we are not sure like what they are capable of, and having that conveyed to us in a respectful and evidence-based way, which all too often does not happen in the US. And also issues of domestic violence and violence against women and children, and gender and sexuality development. And so we just wanted to kind of ground our conversation in understanding that, like, I kind of like to think about it as if reproductive health is a wheel, like these are all the spokes, and the integrity of the wheel, or the health of a human being, or in their reproductive lives, of which we all have reproductive lives, whether or not we choose to procreate or not, most of us have the potential to procreate. So we will all spend a period of our time either trying to do that or trying to prevent doing that. If one of these spokes is knocked out, then it does disrupt the rest of the wheel and the rest of the integrity of the wheel. And we'll touch on this later, but there is a framework that was developed by Black women in the US called Reproductive Justice that really codifies this notion of everything being really interlinked. But before we talk about that, it's very important to acknowledge that when we talk about reproductive health in the US, we would be wrong not to start our conversation with a really sober understanding that just as dynamics of sexism have mediated the laws and the practices around family planning in this country, so too have structural dynamics of racism and ableism. And so I just threw on the slide here some of many transgressions on the hands of the US government on people who were already marginalized in order to either engage in forced sterilization, which in 1927, this Supreme Court case, Buck v. Bell, ruled that the forced sterilization of people is constitutional, which by today's standards, of course, is gut-wrenching. But that's the history, that's the recent history we're dealing with when we talk about modulating fertility. In 1950s, when they developed the first birth control pill, they did this through testing on a group of Puerto Rican women who investigators after the fact can find out that these women were not informed of the life-threatening side effects of blood clots that come with birth control pills, especially the first ones that were developed that had higher hormone levels. And then in the 1970s, the Indian Health Service, which is the government delivered healthcare system for Native Americans in the US, permanently sterilized a group of Native American women. And so as we engage in this conversation, it's really important to understand like just how complex it is, and just how many the forces of racism and ableism and sexism influence a lot of things in our country and our conversations, and abortion is not an exception. So thinking about that is just a really important thing to keep in mind as you consider the complexity of the conversation, and also how important it is to do justice when do justice by the gravity of this conversation when we talk about it, and move beyond the polarized conversation we have today. And just to expand on that, so just as we saw on the last slide, there have been moments where the US government has acted with violence and engage in extreme forms of structural racism with respect to reproduction, we still see today many aspects of women's reproductive lives, especially women of color, being negatively impacted by issues that the US government could address. For example, as many of you probably know, women of color continue to have higher maternal mortality rates and also endometrial and cervical cancer rates than white women. And Black women continue to report negative experiences in healthcare settings. And this is due both to a history of the structural racism that manifests within the medical establishment, but also a current experience of a lack of bodily autonomy and an experience of coercion, which doesn't just happen with respect to things like sterilization, which we documented on the last slide, but also with other aspects of reproductive health. Like when you think through that list of reproductive health, it's also in the way Black women want to give birth. There are really shocking accounts, and you can look up on the internet, of coercion in birthing practices. And then still today, since we're talking about abortion, Black and Native American women are less able to access safe abortion care than white women because of the Hyde Amendment, which is an amendment that's added to a bunch of our laws in the US in order to get bipartisan approval, which bans any use of federal funds for abortion care, which means if you're someone who uses Medicaid or gets your care through the IHS, the Indian health system, you can't access abortion if you need it. So then it becomes a situation where if you can afford abortion, you have access in this country. And then also, I just want to say, this isn't on this slide, but it's also important to acknowledge like all of the other aspects of reproductive health on that previous slide, like something like sex education. Women of color consistently report not receiving sex education that is accurate at greater rates than white women, for example. And so when we think about this, we again have to really be careful to acknowledge like how multifaceted this issue is and how many existing inequalities lead to the realities around abortion in our country today. And I put this quote up here because Dr. Kiara Bridges can say this much better than I can. And she says, "What I've said has underscored the need to refuse or resort to describing abortion as a necessary evil. Such a framing concedes that abortion is evil, which is a conception that fundamentally misaligns with most people's experience of terminating an unwanted pregnancy. For poor Black people in Louisiana and across this country, abortion is necessary because of the evils of structural racism." And I love the way she frames this because she focuses our attention on something that too often our public debate misses entirely, which is why is it that poor people and women of color are seeking abortions more often than white people, yet are denied abortions when they try to make that choice for themselves? Well, that's because of the pre-existing structural inequalities that are mediated by racism. And then on top of that, when they try to make that choice and are refused at greater rates than white women, we can see how the problem compounds and further restricts the agency and flourishing that a framework like reproductive justice demands. So with that, just to talk explicitly about reproductive justice, this, as I mentioned before, is a framework that we owe our thanks to Black American women who developed this in the 1990s as they were reckoning with the fact that the conversation around maternal health care and abortion and contraception was largely just white women talking about issues that mattered to them and did not have the representation of women of color in the US. And they also noticed that it kind of defaulted to this pro-life, pro-choice dichotomy, which completely missed the reality of their lives as lived. And so they made this framework, and I would encourage everyone who's interested to look it up and read about it because there are so many great writings by these women and others who have followed in their footsteps that are talking about the implications on a policy and structural level of taking a framework of reproductive justice seriously. But simply put, reproductive justice is the notion that all people have the right to bodily autonomy, to have children, to not have children, and to parent their children in safe environments. And so that means equity in birthing care, maternal care, prenatal care, abortion care, access to contraception, access to accurate sex education, access to parental leave, access to health insurance, access to affordable childcare, access to healthy food and grocery stores, and so much more are critical to ensuring access to reproductive justice and trying to move away from the historical precedent we have of limiting people's access to a reproductive life that reflects the principles of reproductive justice. And it also, this framework reminds us to check our assumptions, right, of who should or who should not have children or parent, because all of us have biases that are influenced by many different things that we consume in the media or not. And it's important to recognize that these structural biases include racism, and to check our own assumptions about who actually chooses what, when, and how to have a child. That is something that should be equal among all of us, but historically has not been and continues to not be, as reflected by our laws. Okay, so some quick facts. Now that we've laid out that really important framework that Olivia and I love and feel so grateful to have as a grounding space for us to build our thoughts on this issue, and we hope you will too, we just want to dive into some facts, because these are also missed in the conversation we alluded to at the beginning of this presentation. So one, abortion care is very common. As you can see on the slide, we wrote out just some different statistics, but essentially by age 40, over a quarter of women will have had abortion care in their lifetimes. And that's a lot. It should stop you in your tracks to think that for something that affects 1/8 of our population, we don't talk about it in a way that is respectful or kind very often. That, for me, is appalling, because things in medicine that affect far fewer people we talk about all the time. And so I really hope that we can all create a world in our own communities, conversations that reflect and respect this reality. Also, most of people who are seeking abortion care are already parents. 66% of people seeking abortion care already have children. And so when we hear narratives about, that demonize women who make this choice, it's really important to understand that the vast majority of those women are already mothering. And to make assumptions about their lives when they already are taking care of children, I think comes with another set of considerations and reflections. So important to keep that in mind. Also, the vast majority of people seeking abortion care have incomes that are within 200% of the federal poverty level, which for me is something that is also very sobering, in that it really drives home the point that while our conversation right now is about abortion, this is a larger conversation, right, about structural inequity. And it is incumbent on all of us to ask, why is the case that poor women are needing abortion way more than wealthy women? What is it that gets a woman to have to make that choice in the first place? And those conversations are just as important. It's just not the conversation we're having today. And then only 1.3% of abortion care happens in gestations greater than 20 weeks. And the vast majority of these later term abortions, which are also often the subject of very intense emotional conversations in our political dialogue, are usually because of tragic events in the course of a pregnancy that is very desired. And so I really have respect for the parents who have chosen to terminate their pregnancies after learning that their fetus is not viable. Many of them have started speaking out against the narratives that don't do justice to their realities and how heartbreaking it was. And I would encourage anyone who's interested to look up those narratives, because the conversation we have about quote unquote late term abortions just categorically doesn't reflect the tragedy that most parents are facing when they make that choice. And then legal abortion care is safe, and like big star around the word legal here, because if it's not legal, women are going about abortion care in their own ways. And I'll get into that in a couple of slides, but the risk of mortality in birth is over 30 times higher than that of having abortion care, and over 100 times higher if you're a Black woman in the US. And there's no correlation between the number of abortion restrictions in the state and the number of abortions performed, which I'm going to go into in some diagrams because I think that's easier to see visually. So I love this little schematic, and it shows it's they kind of segregated the outcomes of different policies based on the change these policies had in the actual abortion rate from 2011 to 2014. So for these states that had a larger than average decline in the abortion rate, the states in light blue are states that put new abortion restrictions, and the states in this darker blue are the ones with no new restrictions. And then as you see, like for larger than average decline rate and decline rate, the states that had no new abortion restrictions were the vast majority of those states, versus the increase in the abortion rate, more of the states that had new restrictions saw an increase in the abortion rate, which kind of begs the question of like, is law the best tool to reduce the abortion rate in this country? And then here is another really important consideration when we consider whether or not law is the best tool we have to address the realities around abortion in our country. And it's the fact that the abortion rate does not change, but the safety of the abortion does, based on how restrictive abortion laws are. And again, if you're interested in like these studies and how these numbers were found, just head over to the Guttmacher Institute and you can read all about it. We just don't have time to go into it. So Olivia will take it away here for some more conversation.
Awesome. And yeah, apologies if we're going over this. I think we've touched on, but just to say again, there's some really cool data now about the effects of when family planning and reproductive health is actually available and accessible and what that means. And so Lexi and I both love a couple of these studies that show really wonderful things. So that in states where there are more family planning programs and funded ones, there's lower infant mortality rates. There are higher education and employment prospects for women who live in those states. There's lower HIV and AIDS transmission rates. This is also really, really interesting that every dollar invested in publicly funded family planning or reproductive health services saves over $7 in Medicaid expenses. And in 2014, publicly funded family planning programs prevented 700,000 abortions. And it's also super important to realize that states with more abortion restrictions are also less likely to have expanded Medicaid coverage to include contraception and to have higher rates of maternal mortality. So we hope you're starting to see some kind of threads here about when we restrict women's ability to kind of control their own fertility and to access abortion, we get more maternal mortality, and that's not a coincidence. Those are related. And if you go to the next slide, so we touched upon this earlier. This is a really, really interesting study. We are happy to kind of send you links about it if people want to read more after this talk. But the Turnaway study is really the first prospective longitudinal study. It came out of UCSF in San Francisco to really study the impact of what it does to women when they're denied abortion care when they want it. And so this study looked at over 1,000 women from 30 abortion facilities all around the country over the course of 2 years. And some of these women were able to access abortion, and some of them came too late in their pregnancy to be able to, and so ended up giving birth. And the study then followed these women after to see what happened. And so we've just highlighted here some of the findings that we find particularly compelling. Some of the findings for women who were denied an abortion include that they were 4 times more likely to then live below the federal poverty limit. They're more likely to experience pregnancy complications and difficult births. They're more likely to have mental health struggles and to end up with abusive partners or to stay in those relationships. They're more likely to die during pregnancy and during childbirth. The women who were able to access an abortion, you see that they're, and the women who were denied an abortion, their children were also less likely to meet developmental milestones and more likely to not be able to pay their rent and other living expenses. The women who had access to an abortion, afterwards, there's this common myth that people have regret after they make this decision. And one of the most powerful findings of the study was being able to say definitively that's not true. 95% of the women who accessed an abortion years after said it was the right choice for them and looked back on that choice as something that they agree with and thinks enabled them to be where they are today. They also were more likely to have a positive outlook on their future as compared to the group of women who were denied abortion care. And this is, I'll just touch briefly. I think that, so as I mentioned, I work for a doctor in Amsterdam who runs an organization where she provides the abortion pill to women who live in countries where it's inaccessible. Either it's illegal or it's de facto illegal because it's impossible to access. And a lot of what we did there is through medical consultations, basically talk to them and understand where they're coming from. And I was very grateful to be exposed to women from lots of different countries and to really see the impact of what it means to live in a country or a place that makes abortions completely out of reach. We worked a lot, particularly with women in Ireland and Poland. And you saw what happened, as Lexi mentioned before, when abortion isn't accessible, people don't stop getting abortions, they just have unsafe ones. And we worked a lot with women who had serious health complications from trying to do that. It also became clear, and it was interesting, I worked there post-2016, and post-2016, this organization started to get a lot of demand from women in the US. And I think one thread we hope to sort of knock over the head is even if abortion is legal, it doesn't mean it's accessible. And a lot of these women lived in states where one would think you would be able to get an abortion. Blue states, states where you should be fine. It's not the case. There are lack of clinics, it's expensive, transportation, there are all these logistics that you don't think about. And it's a very scary world to begin to imagine what happens when women feel like they have no choice but to go the sort of backdoor route. And that still happens. That's not a thing of the past. And I think it's important to be cognizant of that. And I think Lexi, yeah, okay. Additionally, we also wanted to, again, we know this is a US-centric conversation, but our abortion policies have impacts around the globe. So we want to briefly touch on the Mexico City policy, or the global gag rule, which basically requires that foreign NGOs that receive any US global assistance have to guarantee that they will not perform or promote abortion as a method of family planning. There has now been some really, really interesting data that has shown that women living in countries that were exposed to the impact of the Mexico City policy were then 2.73 times more likely to have an induced abortion during the years that policy was active. So from 1994 to 2000 in that study, than when that policy was not in place. This data also found that the rates of unsafe abortion dramatically increased under the rule, which increased rates of maternal injury and mortality. So again, speaking to the fact of when it's not legal or well-funded, it doesn't go away, it just becomes unsafe. And yeah, and I think also one thing to quickly flag here about the Mexico City policy is you also saw that when organizations got their funding taken away, it also took away funding from other reproductive health services that Lexi highlighted earlier. So things like prenatal care or contraception or STI care, those things went away too. And so women were harmed. Lexi, take it from here.
Okay, I know we've gone way over our allotted time, so I'll try and be brief here. But I think just I want to share some perspectives I've had since starting medical school and how it relates to my thinking on this issue. And I think being in medicine, like the biggest thing it has imparted on me so far is just a radical sense of humility for the fact that no patient you see is going to have the same body, same needs, same preferences, convictions, lived experiences. Every interaction you have is with a different human being. And as we've seen about like the historical realities of certain communities with respect to family planning, and as we've seen from like the way poverty interfaces with the need for abortion care, like when you see a patient, you see someone who is entirely unique. And our job as physicians is to listen to someone's story in its entirety and take this all in. And so when there are laws that prevent that important raw human conversation from happening and prevent physicians from attending to those needs, it really limits your ability to answer the call of medicine, which is to serve your patient's needs. And then something else, one of my role models, Dr. Lisa Harris, says is that ambiguity is, well, she speaks about this at length, so please look her up if you'd like to read more, but she talks about how ambiguity is a part of all aspects of human reproduction and how women have birth is different, and if and when people choose to reproduce or have an abortion is just going to differ. And so really understanding the ambiguity is the lens through which we should see these issues, leads us to better serve patients than adopting like any sort of black and white perspectives around the issues. And then just political labels around abortion, as I've mentioned before, they're very, very useful in political life. Like they win millions of votes on so many elections, but they are never useful in the doctor's office. I have shadowed multiple abortion providers at this point in my medical training, and never once have I seen a woman who's coming in for a consultation about abortion care, considering whether or not to get that care, ever say that she is pro-choice or pro-life. That never comes up. What does come up is her concerns for her other kids and her desire to provide a good future for the kids she has, and her worries about losing her job, and her worries about her abusive partner. So it's just very weird to see that divide. And as we mentioned before, like we want to have this conversation with all of you in the hopes that we have conversations that reflect that reality. And then one of my mentors at Stanford has said, determining if, when, and how, and with whom to have children is one of, if not the most life-changing decision of a human being's life. And that's something I always try and keep top of mind when thinking about the seriousness of doing right by patients that need abortion care. And then very quickly, just wanted to touch on like, why is abortion so hard to talk about besides things we've already talked about? And I'm sure many of you are aware of the fact that like we don't really do well having really candid and caring conversations about sex in the first place. And so it's not surprising that our political conversation around abortion never really talks about how sex is involved to get to that decision point, most often between a man and a woman. And since we struggle with that so much, it kind of begs the question, like, where does that leave us to talk in a caring and considerate and open and grounded way about the consequences of sex? So I am definitely of the opinion that having respectful conversations about sex is a very important piece of the puzzle. Also, our conversations about women, a lot of times there's an implicit assumption that a woman's most important role is to bear children, and a lack of understanding that many women do not desire this for themselves, whether for a period of time or for their entire lives. And then also stigma. Stigma is something that marks something, a person, an idea as less worthy. And by extension, if a person takes an action to stigmatize it, stigma unfortunately makes us consider that person less worthy or less fully human. And we don't talk about things that are stigmatized. And so the frustration there is like when we have silence, we kind of think that abortion is unusual and rare, which is so far from the reality, as we've seen in the conversation. So we just love everyone to consider that when you hear a conversation about abortion, just ask yourself, well, when was the last time I heard a conversation about the real impact of an abortion in a woman's life? And how can we modulate our conversations to shift towards that actual lived experience instead of what is politically expedient? And then the graph again, and this quote that Olivia and I both love, which was by Justice Blackmun in the Roe v. Wade decision, which was so consequential for abortion rights in the country. And he says, we need not resolve the difficult question of when life begins, when those trained in the respective disciplines of medicine, philosophy, and theology are unable to arrive at any consensus. The judiciary at this point in the development of man's knowledge is not in a position to speculate as to the answer. And this is our last slide. It's kind of our thesis statement, if you will. We want a future where our healthcare's principle is its patients. And to do this, we must engage in nuanced conversations about abortion, which are grounded in the diverse lived experience of our fellow human beings. And we believe our laws about abortion will never be humane, and by extension, our medical care around abortion, until our conversations are. So thank you so much for being a part of this conversation, and we're really excited to hear all your questions.